first of all, why do we need this class? Why are we so much, worrying about contraception, and why was Dr. Kishan so particular that we should have a session about contraception? Two main reasons. One is the population explosion. All of you know that we are one of the most populous countries in the whole world, and population explosion is a serious threat for so many advances which could actually happen in our country, right? So that is one of the most important, need for contraception for us to control the population explosion. Okay, and thankfully, with the intervention from Government of India, steadily the total fertility rate is going down. You can see that the steepest decline was seen during the last census. The TFR came down to 1.64, the average total fertility rate of India. Okay, so that is one important thing. Another important thing is to avoid unnecessary abortions, especially among younger population. You know that abortion is extremely liberal in our country. We have over-the-counter drugs available, so it's very easy, if you get pregnant, okay, let's take an over-the-counter abortion pill. It is not that simple. Please remember that contraception is any day much, much, much better option than an abortion. Okay, even though you may feel that why do we need to take a pill for every day, whatever, to avoid one pregnancy. If we become pregnant, we always have abortion pills. No, please remember that abortions are associated with their own complications. Okay, it may be fine in most of the cases, but whenever the complications occur, it becomes extremely ugly. You'll be having significant bleeding. You may get infected. The long-term sequelae of infections like tubal blocks and endometrial atrophy, all these problems can happen. So we can't take it for granted that anyway abortion pills are available. Contraception is a much, much better choice than abortives. So these are the two important things. Okay, one is to control population, other one is to avoid unintended pregnancies, which will lead on to abortions. Okay, that is our need for contraception. There is another concept called as unmet need for contraception. What do we mean by this? Basically, when we say unmet need, what we mean is that there are a set of women in our country or anywhere in the world who need contraception but are not using contraception. The causes can be anything. Okay, the causes can be like, there is no support from the family, the husband, the mother-in-law, they don't want her to follow any contraceptive method. The family she may not be aware of different methods available, the lack of awareness. Okay, family may be like, she may be staying in a very remote area and she has to go to a health center which is situated far away and she can't afford to go all the way. So there are the different reasons for unmet need. Okay, but remember that is one of the important things you should remember, because whatever we try to, implement from the government side, we should remember that there are almost 20% of women in our country who actually need contraception, but they are not using contraception. So these are two important concepts you need to know. And to start the introduction, one of the common questions asked for you guys is, what is the approach for contraception? Okay, so the approach can be summarized as a cafeteria approach, basically. Okay, cafeteria approach means when you go to a hotel, what exactly happens? Will the server or waiter will come and dump some dish on you? This is the only thing available. You eat this. That doesn't happen, right? What happens is they will either give a menu to you or they will tell what all is available in small hotels. But wherever it is, a big hotel or a small hotel, you have a choice. That is exactly what is cafeteria approach. So when a patient comes to us who needs contraception, or we realize that they need contraception, the approach is something called as GATHER. GATHER is an acronym. Okay, so basically it is like, build a good rapport by greeting the patients and asking about themselves. Then you tell the patients about what all are available for them. This is your cafeteria, idli, vada, dosa, puri, whatever, that kind of thing. You have to tell about what are the different choices available for them. Then you help those patients to choose. Okay, let them make an informed choice, right? You tell them about the pros and cons of each method available and then let them choose. Once they choose, you tell them how to get access to it. Okay, whether you will be able to do it or they can do it themselves, because there are a lot of user dependent and healthcare worker dependent methods. So you'll have to explain to them how it will go on. And then the most important is ask them to return for a follow-up. It is very important. So this is what is GATHER approach. Okay, now let's see what is an ideal contraceptive. Okay, most probably if you look at this list and if you come back to this list towards the end of the presentation, you'll realize that as of today, we really don't have an ideal contraceptive. Okay. See, inexpensive, whatever is inexpensive may not be safe, may not be, accessible, whatever. It becomes like that, and all these factors of inexpensive, being safe, simple to use, widely acceptable, easy return to fertility, okay, should require minimum motivation. Motivation is a big problem in contraception. In our postnatal clinics, we'll be literally telling them so much about different methods available free of cost. Forget about inexpensive. There are so many methods available free of cost under Government of India. Okay, even then it is so difficult to motivate women to accept some form of contraception. It's really difficult. Okay, and should require minimum maintenance. The woman, if she agrees to use, should not worry about how she is going to maintain it. Okay, and supervision from the health workers also should be minimum, so that she need not come to hospital again and again, or the healthcare workers need not go to her again and again. So these are the few properties of an ideal contraceptive, and as I told already, it is not possible that we have an ideal contraceptive as of today. Probably some of them may fit into it, but somewhere they'll fail in this particular thing. They're quite expensive methods. Okay. So now let's brush through the anatomy which is relevant for contraception for us. Anatomy is very simple. All of you know it. Okay. We have a uterus, okay, where the pregnancy actually grows, and we have this ovaries where the eggs are produced. Okay. The tubes which connect the ovaries to the uterine cavity, but it is not actual connection. We have the fimbria, the part of the tube which is attached. One of the fimbria will be, it's called as ovaria fimbrica, which will be slightly adherent to the ovary, and the orientation is such that whenever the egg is released, it will get retrieved by these fimbria, and that will be transferred across to the ampulla. And this is where the semen is deposited, the vagina, where the uterine cavity opens up through the cervix. Okay, this is where actually the semen is deposited during the act of intercourse, and the semen will ascend up. Okay, and they will go and meet the ova somewhere in the ampulla here. The fertilization occurs at this site only. So you know that the sperms are much more motile. Okay, they have a motility, so they will traverse a longer distance and come to the ampulla. The ova has to just reach the ampulla. The fertilization occurs over there, and then the whole the fertilized zygote gets transferred across to the uterine cavity and gets embedded in the uterine cavity. That is what is the relevant anatomy for you people. Then we have few things about physiology. Okay, physiology, which is relevant to contraception. All of you know that there are two parts of menstrual cycle, and there are certain hormones which are elevated in the first part and certain hormones elevated in the second part. Okay, so remember all these things. And most important is this FSH. Can you see this follicle stimulating hormone? As the name suggests, this is the hormone which is responsible for the growth of follicles. Okay, and which will eventually lead to a dominant follicle, which will become mature, and it will rupture under the effect of luteinizing hormone, leading to release of the ovum. That is called as ovulation. Okay, and then the remaining graphene follicle gets converted to corpus luteum and secretes the progesterone, the predominant hormone in second half of the cycle, which is a thermogenic hormone, and this hormone is responsible for making the cervical mucus thick. Okay, so this is a relevant physiology for us from point of view of contraception. Okay, so now let's look at what are the different methods available. This is the complete overview of what are the different methods available for us. Again, not in detail, I'm just telling you the subheadings over here. The most important classification will be temporary methods and permanent methods. Okay, among the temporary methods, we have natural methods, barrier methods, hormonal methods. Okay, oral and non-oral. The hormonal methods can be made available as oral, or it can be non-oral, like injections, implants, whatever. Okay, I'll talk about it in detail later. And non-hormonal methods, mainly IUCD, that is COPD, commonly called as COPD. Okay, the permanent methods are again the surgical methods of female and male sterilization. Okay, so now one more important thing you need to know before you start counseling the patients regarding a contraceptive method is Perl Index. Okay, so Perl Index is basically, it is a measure of efficacy of a contraceptive method. Okay, it is defined as the number of failures per 100 women years of exposure. It is not how good the method is. It will tell you how bad the method is. Okay, so effectiveness of a contraceptive method is high if the Perl Index is less than 10. Okay, and it is low if Perl Index is more than 20. And remember, what's most important is Perl Index is not a single number for any method, especially methods which are user dependent. Okay, for user dependent methods, like where the patient has to remember every day and take a pill. Okay, all those methods, what happens is there is an ideal use Perl Index and typical use. Ideal use is you have counseled the patient or advised the patient to use it in particular way. If she uses it in the same way, then it will lead to ideal use Perl Index, which is very low actually. And if it is a typical use, you know what happens. You know, you advise a patient to take the pill every day for 3 weeks, whatever you advise, she may miss one pill there, one pill here. It happens. Like, it's human to forget, like. So, the typical use is basically how people generally use them. So that is going to be higher. Some of the methods, the difference is really, really glaring. Okay, so remember the Perl Index. That is the failure index of each contraceptive method. So now let's move on to different methods. Number one is natural methods. Natural methods are basically where we don't use any form of external things like barriers or hormones or non-hormone, whatever. Okay, it is just knowing the physiology, we'll try to adapt and we'll try to control the fertility based on that natural methods. Okay, so basically what are the important factors we should know when we follow natural method is human ovum is probably susceptible to successful fertilization only for about 12 to 24 hours. That means the maximum lifespan of an egg or an ova is only 24 hours, up to 24 hours. Okay, for a sperm, once it is ejaculated and deposited in the female genital tract, it can remain alive for 5 to 7 days. Okay, but the ability to fertilize is only for around 24 to 48 hours. I just want people to remember the lifespan of a ova is 24 hours after ovulation, and for sperm, once it is deposited in genital tract, it's up to 48 hours. Remember one number at least. This is very important information for you people. Based on this only, we'll be using the calendar method. The next slide we'll be learning about it. And as already mentioned, cervical mucus is hormone sensitive. Okay, the progesterone makes it thick. Under the influence of estrogen, it is going to be thin and stretchable, and under the influence of progesterone, it becomes thick and brittle. Okay, and progesterone is a thermogenic hormone. It will increase the basal body temperature. Once it starts getting secreted from corpus luteum, it will increase the basal body temperature. And one more important thing you should know is there is a hormone called as prolactin, which is secreted predominantly during lactation, during breastfeeding. That is a hormone which inhibits ovulation because it will decrease the level of LH in the body. Okay, so we'll again learn a little bit more about these methods. But what are the different methods available for us? We have a calendar method that is the rhythm method, which will basically depend upon the information what I told you in the previous slide. That is human ovum is susceptible for 24 hours and sperm remain alive for 48 hours, and ovulation occurs somewhere around 14th day. Okay, this is the information we're going to use, and we're going to apply that information into a kind of rhythm method. According to rhythm method, the first 7 days and the last 7 days of a regular menstrual cycle, please remember, if the cycles are regular, only then we'll be able to adapt this particular method. In irregular cycles, it becomes extremely difficult. It is not advised at all. If the cycles are fairly regular, 28 to 30 days kind of cycles, then we'll be able to apply this particular method. Either you practice abstinence during the middle of the thing, or we can use some other method like condoms or something like that during the unsafe period. It's called a safe period and unsafe period from pregnancy conception point of view. Okay. Then we have basal body temperature method, which again depends on the fact that progesterone is a thermogenic hormone and there is an increase in the basal body temperature once progesterone starts getting secreted. Okay. That's also a good method. There are graphs available like this where woman will chart her basal body temperature, which is measured first thing in the morning before she gets up from the bed, and she will chart it. And the important thing about how do we use it for contraception is 3 days after the temperature rise, she can resume unprotected intercourse. That is what information what we give for BBT followers. Okay. Similarly, cervical mucus method, I told you cervical mucus is hormone dependent. It will be thin and stretchable like this. This is called as a spin barket phenomena. Okay, thin and stretchable like this under the influence of estrogen, and once progesterone is secreted after the ovulation, it becomes thick and brittle. You can't really stretch it like this, it will break. Okay, so how do we adapt this for contraception is after 4 days of onset of the thin mucus, we can ask the patient to have unprotected intercourse. She can have unprotected intercourse, okay, for contraception. Okay, then we have a symptothermal method which uses both these methods together. Okay, there the failure rate is much better. See, all these are in case of regular cycles and in case the patient is educated and she's able to understand what is the temperature rise, able to monitor the temperature and all those things. Okay, so even the cervical mucus, they should know exactly how to check for cervical mucus, what is thin mucus, what is thick mucus, and all this stuff. Then we have a persona kit. This is a kit available which depends. You have to put in a few drops of urine in the thing provided there. Okay, well provided over there, and it will give a red or a green light, and red means unsafe day and green means safe day. They've tried to make it as simple as possible by use of a machine. Again, it's pretty expensive, and every cycle you need a new device, so it is not possible. Okay, so among the natural methods, the most commonly used is a calendar method. Most of the educated couples where the female is having regular cycles will depend on the calendar method when they're practicing contraception. But again, remember, the chances of failure is pretty high. The Perl Index is as high as 10 to 35%. So it is not very advisable. And another one is the lactational amenorrhea method. I think this is the most commonly practiced natural contraceptive method among our women, Indian women, because you know that almost all of them breastfeed the baby, and exclusive breastfeeding is practiced by most of them for the first 6 months. Whenever it is exclusive breastfeeding, then there is enough secretion of prolactin to inhibit the release of LH. So there is no ovulation occurring. Okay. But you have to remember that once exclusive breastfeeding is stopped, you start weaning the child, then it's not going to be effective. And you need not think that, okay, I've not got menses, so I'm still protected. No, 6% of women actually ovulate before the first menstruation itself. Okay. So it's very important to remember that it is extremely useful in the first 6 months. But once you have started weaning the child, you can't depend on amenorrhea part here. Okay, now coming to the next method, it is barrier methods. Barrier methods, again, one of the most commonly used method is this male condoms. Okay, and others are available, but we are not really using them that much because diaphragms and cervical caps are available under Government of India, but we don't have many takers for that. Okay, cervical caps are available commercially as Fem cap and Lee Shield and all. This is cervical caps. These are the diaphragms. Okay, but they are again coital dependent. You have to use them during the act of intercourse, like condoms and other things. So again, all these methods are not very. This contraceptive sponges and all this stuff are really expensive. So we can't really adapt them in a larger scale. Okay, but all these 5 methods can be used by the female, right? The female independence will be there. So in conditions where men are not willing to use some form of contraception, these will come handy. Okay, so just remember that among the barrier methods, the most important is male condoms. I'll be again speaking about, this is a picture of male condom here. Okay, this is the spermicide jelly which can be inserted into the vagina high up. Okay, this is a female condom. There are 2 rings at both the ends. Okay, one of the end will be closed, another end will be open, which will come on the genitalia. It can be used with spermicides, or some of them are available impregnated with the spermicides. So that is how the female condoms look. Okay, now let's look at the condoms. Condoms is something which you should know how to advise men how to use it. Okay, for yourself or for the sake of people who want to use, you should know exactly the correct use. Okay, the most important points for maximal condom efficacy is correct use and consistent use, and obviously affordable and easy availability. You know that it is available free of cost under Government of India's Nirod, okay, and it is easily available in all the pharmacies across India commercially also. Okay, so what is most important is consistent use, that is, use condoms for every act of intercourse. Okay, and correct use. How do we correctly use a condom? See, remember one thing, as medicos, you should not hesitate to tell these things to the patient. It's extremely important that you overcome the inhibitions of talking these personal things and explain to the patient. Usually, we insert a condom on our test tube or something like that and demonstrate to the patients before we advise them how to take it. Okay, there are people who have no idea. In the PHCs and all, they won't know anything at all. They'll think they're balloons if they're lying loose somewhere. Okay, so please remember that you have to talk to them properly and tell them. Most important is place the condom before vaginal contact once the penis is erect. Okay, and create a reservoir at the tip by pinching and expelling the air. This is a very important step. Can you see this? The tip should be pinched so that you create a reservoir. Otherwise, what will happen? They can, when the semen is deposited after ejaculation, it can increase the pressure in the tip here and the tip can burst, leading to failure of contraception. So it's very important to create a reservoir at the tip by pinching and expelling the air. And you should also tell the patient withdraw while the penis is still erect. Otherwise, what will happen once the penis becomes flaccid? The condom will just get dislodged, or the semen can escape into the vaginal area. Okay, so again, it will lead to failure of contraception. And when you are withdrawing, always hold the base like this and then slowly withdraw. Okay, so that is, they are the different things we have to tell the patients when women, men, not exactly patients, men who want to use this particular method. This is how we advise them. Okay, now the next important thing is hormonal contraception. So we learned what is natural methods, what are the different natural methods, and we learned what are the different barrier methods. Now let's move on to hormonal contraception. Again, one of the most important thing, because it's freely available under Government of India. This, whatever I've underlined, the combined estrogen plus progesterone pills and progesterone only injections are available freely under Government of India. Okay, so it's very important to know about these things in detail, but you should also know what are the different other things available. I told you hormonal contraceptives can be oral or non-oral. So oral formulations are combined estrogen progesterone pills and progesterone only pills among women who cannot use estrogen. Okay, there are certain contraindications for estrogens. I'll come to it. There we can use progesterone only pills if the patient wants a pill format. Okay, if they don't want pill format, then we have many other options for them. We have injectables, which can be again combined estrogen progesterone or progesterone only injections. We can have implants, which are as of now only progesterone. Intrauterine systems, again only progesterone. Okay, and this is a very common thing, Mirena, which is easily available. But in our country, I think in our setup especially, we use it mainly for gynecological problems like abnormal uterine bleeding, adenomyosis, endometriosis, those things, rather than for contraception. Contraception, generally, we go for non-hormonal IUCDs, but hormonal IUCDs we generally use when woman already has some problem like abnormal uterine bleeding or something like that. Okay, vaginal rings, the combined estrogen, progesterone and progesterone only, both formulations are available, and transdermal patches. Okay, transdermal patches, as of now, combined estrogen, progesterone only is available, which has to be applied for 1 week duration. Vaginal rings are for 3 weeks, so it's one cycle basically. But progesterone only patches are undergoing trial. In the bracket, whatever I've given is the Perl Index. Look at the Perl Index, exceptionally good, less than 1%, most of them. But again, look at the oral pills, because they are user dependent and the typical failure rate is as high as 8% here. Okay, for POPs it's as high as 10%, around 10%. But rest of them, which are not user dependent, like injectables, implants, and intrauterine systems, you can see the failure rate is so good. Actually, among implants, we have different implants like Norplant, Jedel, and Implanon. Implanon is the recent single rod implant, which will be implanted in the arm under the skin. It's a subdermal implant. Okay, and the failure rate was 0 in many of the trials with Implanon. So only contraceptive method with a known failure rate of 0 in the research, in the trials, clinical trials, was Implanon. Okay, Implanon is a single rod implant. Okay, which contains a progesterone called as desogestrel, a third generation progesterone called as desogestrel. Again, very expensive, not easily available in our country. We had used it under an ICMR trial in JIPMER actually, and we found that acceptability and continuation rates were pretty high with this particular contraceptive method. Okay, then we have, I think among all these, you need to know a little bit more about oral pills, that is combined estrogen progesterone pills and progesterone only injections. Let's move on to COCs. So COCs, actually COCs itself is a class I usually take for 2 classes, 2 hours actually. So I'll try to tell you what are the different, under what all different subheadings you should know about combined oral contraceptive. Please, Medicos undergraduate students, remember that this is not a final class. There is lot of scope for self-study, further study in this from this particular class. I'm only going to give you the outline, that's all. Okay, otherwise it's not possible to cover this particular topic in 1 hour. I'm telling you again because I don't want you people to think that this is enough for you. This is not enough for you. You need to know more actually. Okay, so combined oral contraceptive pill, I told you it is again very important to know because this is what is available, Mala N. Okay, actually N in Mala N used to stand for norgestrel. Initially it used to contain norgestrel, but then they change it over to levonorgestrel. Okay, and N you can remember as nil paisa or naya paisa. It's free of cost. Okay, under Government of India, it's available free of cost. So what are the contents? Each combined pill, as I already mentioned, contains estrogen, which is ethinyl estradiol in all the pills. Okay, in terms of estrogen, the differences are basically by the dose of estrogen. How much does each different type of pill, what dose it contains? Initially, when the oral contraceptive pills were introduced long ago, it used to be as high as 50 micrograms. Okay, but then slowly it came down to 30, 20, and now it is even 15 mics available in India in a pill called as Menace. There are even in US up to 10 micrograms they have gone down. At the contraceptive, the least contraceptive efficacy of a pill available in India right now is 15, but trials are on with even 10 micrograms. Okay, it's found to be pretty okay, the by contraceptive efficacy. But why I have underlined 30 here is our freely available pill contains 30 micrograms. Okay, so that is the dose of ethinyl estradiol in the combined oral contraceptive pill. About progesterone, again, this is not dependent on the dose. No, the way we classify them, it is generations. The first generation is norethinolol, then second generation is LNG and norgestrel. I have underlined that. That is what is available in our Malayan. Okay, and then the third generation is disogestrel, and now drospirenone. So what is the main difference between LNG, disogestrel and drospirenone? See, LNG is a progesterone with significant androgenic side effects. Maybe not as high as norethinolol, but they do have very significant androgenic side effects like acne, oily skin, some hirsutism, okay, and the very unfavorable lipid profile. So all these were problems with LNG. These were overcome with disogestrel. The third generation progesterone disogestrel, I told you this is the hormone present in that single rod implant, Implanon, what I spoke about previously. Okay, this is a third generation progesterone. This had very minimal androgenic side effects. Okay, that was an added advantage when we went to the third generation. But the pills containing this hormone, the disogestrel, are pretty expensive. And it is not available free of cost under Government of India. Now, so what is this drospirenone? This is the most recent, the fourth generation progesterone, which has got all the advantages of drospirenone, disogestrel, the least androgenic side effects, a good favorable lipid profile, all those things. Plus, it also has an aldosterone kind of action, which will decrease the water retention in the woman. Okay, so they won't have that bloating, a sort of a feeling of weight gain, and all those things won't be there. So this is a newer one with least androgenic side effects plus aldosterone kind of action, which will decrease the water retention in the body. Okay, this is about the different estrogens and progesterone, but you should know what our Mala N contains. It contains levonorgestrel 150 micrograms and ethinyl estradiol 30 micrograms. Okay, so now that we know what are the different pills available, how do you initiate? A patient comes and you will present her all the different choices and she wants to opt for oral contraceptive pill. How do you initiate? Do we need to do any lab test before starting? What do we need to do? Actually, there is no need to do any laboratory investigation, but we need to take a thorough history and examine her, especially the blood pressure. Okay, among women who are more than 35 years, it's very important to note that if they're smokers. So you know that it's not a very common problem in our setup, but nowadays we do see a lot of women smoking in metros especially. Okay, so be very careful. If the woman is smoking more than 15 cigarettes per day and she's more than 35, it's an absolute contraindication for starting the OC pill. Okay, and we should also rule out other contraindications. Like if she's breastfeeding less than 6 months postpartum, we don't give. If she's having uncontrolled hypertension, we don't give. One of the most important contraindication you should know is if there is past or present history of thrombotic event. Okay, you know that estrogen is a thrombogenic hormone, so we should not give any estrogen containing method if the patient has any past or present history of thrombosis. Okay, and that is how we initiate. So how do we initiate? Patient, we will tell them they cannot start whenever they feel like starting. They have to start it on day 1 or day 2 of menstrual cycle. To begin with, this is the rule. Okay, for contraceptive, this has got the best contraceptive efficacy for us. Okay, but for the next cycle, they don't need to wait for menstruation. Generally, these pills will contain 21 active pills containing estrogen, progesterone, and 7 ferrous fumarate tablets. Can you see? So the active pills will be white in color, and the ferrous fumarate is going to be black in color. So we'll tell the lady to take 21 white tablets first, starting from day 2 of cycle. That is 3 weeks. She will take those pills, and then she will take the ferrous fumarate, the black pills. Okay, after completing the black pill, she'll immediately go on to the next packet. There is no pill-free gap at all when we are using this kind of pills. The commercially available pills do not contain the black pills, please remember. Okay, they contain only 21 tablets, the active ingredient tablets. So there we will advise the patient as start it on day 1 or day 2 of your menstrual cycle. Take for 3 weeks, then have a 1 week pill-free gap and then restart the next cycle again. Okay, that's very important. The patient should not wait for menstruation and again start on day 1, day 2 for the second packet. Okay, only for the first packet we need to start on day 1 and day 2. But for second packet, it is just after 7 days of pill-free gap, irrespective of menstruation, they can initiate the second cycle, second packet of contraceptive. That's about the initiation. Follow-up is also equally important. Basically, you want to make sure that she's compliant and taking the pills properly. That is one important thing. And the second important thing is ask for any side effects. Okay, ask for any red signals like any swelling of the limbs, suggestive of thrombosis and all those things. So a follow-up after starting the pills is extremely important. Okay, now I told you there are certain contraindications. I already mentioned puerperal ladies, high blood pressure, smokers, any history or present condition of thrombosis. All these are absolute contraindications for OC pill intake. There are certain relative contraindication also. WHO has basically provided the medical eligibility criteria for each contraceptive method. Please go through that particular table. You will get to know what are the absolute contraindications for each contraceptive method. For OC pill, at least remember these top 4 things. History or current process of thrombosis going on, uncontrolled hypertension, smoker more than 35 years of age and smoking more than 15 cigarettes per day, and a puerperal lady who's breastfeeding the kid 6 months puerperal. Okay, these are the 4 important things you should remember. Then there are many more. Okay, so please go through that. It's not possible to cover here. Then we'll have certain problems when the patient is on pills. She may come back with these complaints. She can have a breakthrough bleeding. She may not bleed. She may not have the withdrawal bleeding at all during that 1 week pill-free gap. Okay, all this will be bothering her. You should just reassure the patient. It will just take some time. But if the breakthrough bleeding is bothersome, especially this is more common with lower dose estrogen pills, 20, 15. When we use that, this particular problem is high. We can ask them to add additional conjugated equine estrogen during those breakthrough bleeding time, or you can just tell her that if it is self-limiting, if it is very minimal, she can just go through it, that's all. Okay. One important thing in the troubleshooting is missed pills. What do you do if the patient has missed certain pills? Okay. So let's assume that the patient has come to, in the follow-up and she came and told you that I actually missed to take 1 pill. What do I do now? Yesterday night I didn't take. So just tell her missing 1 pill is of not much consequence. Just take both the pills together today night. If she's come today morning to you in the OPD and she's telling I didn't forget to take my pill yesterday, then you'll just advise her to take both the pills together the next day and you go on. That's it. There is no need to do anything else. Okay. But if she's missed 2 pills for 2 successive days, what do you do? If it is in the first half of cycle, you tell her to take 2 pills on 2 more days. Like, today night 2 days, 2 pills, and tomorrow night 2 pills and leave it. But if it is in the second half of the cycle, she should take it like this, plus she has to follow some kind of backup contraception like barrier method or abstinence or whatever. Okay, so it depends. Single pill, no problem. Just take both the pills tonight and finish it off. Okay, continue taking pills regularly later on. But if it is 2 pills missed already, she is not taken for 2 successive days, then if it is first half of cycles, first 2 weeks of the cycle, then she will just take 2 pills on 2 successive days, today night and tomorrow night, and then she will forget it. But actually, there are some recommendations where they say anytime they miss 2 pills, ask them to take 7 days back. Okay, 2 pills or more than 2 pills, it's always better to start using backups, and they should tell the patient that if she has missed more than 2 pills, especially in second half of cycle, then there is very high chance that she may become pregnant. Okay, so anyway, they can start using they can either take emergency contraception. This is the failure of contraceptive method, right? So they can go for emergency contraception, but any day if they want to continue with the pills, tell them to take 7 days of backup. Okay, so now there are certain side effects. Side effects are very nausea. They can feel that they're gaining weight. Then they can have some mood changes, headache. These are common side effects, but these are all it's there in the first cycle and then it will settle down by second cycle, third cycle. Now you just have to reassure the patients. Okay, and most important is the risks or complications. Okay, that is why we are very particular not to give pills to patients with contraindications, absolute or relative, because the complications can be grave. It can be DVT, myocardial infarction, stroke. Okay, so these are the three important things why we are so particular about contraindications. If you give it overlooking some contraindication, they'll end up in severe problems like this. So it's very important to thoroughly take a history and rule out all the contraindication before we initiate ocipils. Then they'll have a higher chances of gallstone formation. Okay, and CA breast is slightly increased in women who use oral contraceptive pill, but it is not very high to worry that you should not prescribe pill at all. But probably if the patient has got a past history of CA breast or family history of CA breast, they better avoid OC pills in those patients. Okay, then there are another two terms here. Try to understand what it is: non-contraceptive benefits and non-contraceptive uses. They're different. When they ask the question in Viva Voce, is commonly asked. Like they'll give you the mala and packet in your hand. They will ask you, what are the non-contraceptive benefits of this method? Okay, that means you're using it for contraception, but there are some benefits for the patient. Okay, that is what is non-contraceptive benefits. So what are those benefits? Basically, if the cycles will get regularized, okay, the amount of bleeding will come down, dysmenorrhea will come down, okay, the chances of follicular cysts will come down. So all these things are non-contraceptive benefits which the woman will get when she is using pills for contraception, that is combined oral contraceptive pills. Okay, what are the non-contraceptive uses? The patient may not require contraception. Okay, she's a para 2, live 2, sterilized. Even then, we may use OC pills for certain indications, like again, abnormal uterine bleeding, endometriosis, severe dysmenorrhea. Okay, so they are all non-contraceptive uses. You're not using it for contraception, but you'll prescribe these pills for other things, PCOD, all those things are non-contraceptive uses. One more important non-contraceptive use is under the benefits, you should also know that they protect against ovarian cancer and endometrial cancer. Okay, at least 5, if the longer they use, more the protection actually. So there is a tug of war between CA ovary, CA endometrium and CA breast here. There is slight increase in CA breast and there is definitive protection against CA ovary and CA endometrium. So it is used in women who are at high risk for ovarian cancer or endometrial cancer by familial, like BRCA1, BRCA2, Lynch syndrome. In those conditions, we use these pills till the patient finishes her family. This is called as chemo prevention. Actually, we use hormonal pills, the combined oral contraceptive pills, for chemo prevention. Okay, and the certain myths and misconceptions are there among general public about the OC pills, like you'll put on weight. Actually, you don't put on weight with oral contraception. This weight is only observed. It cannot be explained. I told you that only thing is the LNG can lead to some water retention. That can be seen as a weight gain actually. So you should tell the patient that no, you're not prone for weight gain. Only if you become very relaxed and eat a lot, you put on weight. That's all. So you have to clear those myths. There's another myth like, OC pills will decrease the fertility. Once you stop also, you won't become pregnant. It is not like that at all. Within 3 months, most of the women conceive when they stop the pills. Okay. So it's very important to know what are the myths surrounding the pills and try to dispel these misconceptions among the general public. This is about oral contraceptive pills. Now a few lines about progesterone only injectable. I told you this is also available free of cost under Government of India. It's available as Antara. This was available as Mala N. Please know these names. Okay, and progesterone only injectable contraceptive is available as Antara. Okay, this basically contains a progesterone called as medroxyprogesterone acetate. 150 milligram is available in 1 ml and this should be given once in 3 months. Okay, and it's highly effective, 0.1 to 0.4% failure rate, because there is no need to remember to take pill every day. So forgetting pill and all those things are not there. There is no typical use and ideal use in this. Everything is ideal only. And obviously, there are no estrogenic side effects. All the progesterone only contraceptives will have this very important thing, because you know that estrogen has its own side effects. So estrogen associated side effects are not there in these methods, and it is most suitable for lactating women, right? Because it won't alter the quality and quantity of the milk, and it won't increase the thrombogenetic state of postpartum period like estrogen does. So it's very advantageous at that time to give the women. It also cures menorrhagia and dysmenorrhea, and it is the contraceptive of choice for sickle cell diseases. Okay, but there are certain side effects. I told you progesterones generally have this side effect of water retention, bloating, mood changes, especially depression, Okay, and most important is there is a concern about decreased bone mineral density with medroxyprogesterone. This is a depot injection, right? There is a concern, so it is not advocated in women who are more than 40 years and among adolescents when they want contraception. We don't generally, because the bone formation is not complete in adolescents, and women who are more than 40 are already prone for bone mineral lessening. So it's not advised in those particular women. Okay. Now let's go to what is the general rule for initiation of non-oral methods. For example, you want to start the depot progesterone injections. Okay, so what's the general rule? If the patient has not used a hormonal contraceptive before, just start it within 7 days from the onset of menstrual period. Okay, but if you're starting at any other time, again you back up for 7 days, and pregnancy should be excluded before using this particular method, whether it is injection or copati, Mirena or implants or whatever it is. You have to make sure that pregnancy is excluded and use additional methods like barriers for at least 7 days. So these are the different non-hormonal methods here. This is a LNG IUS, which contains a hormonal. This is a copati. The system is like a copati, but it contains an active ingredient. Here is a hormone. There is a reservoir for the hormone here. Then we have implanon. This is the rod. Actually, can you see this rod? This is used to place it under in the subdermal place. This is an implant. Then we have injectables, that is the same Depo-Provera, the Antara what we had. Then we have vaginal rings which contain the estrogen plus progesterone, which can be changed once in 3 weeks. Okay. Then we have patches. These have to be applied every week. Okay. So these are the different things. Now let's look at the what are the different mechanism of action. I told you that most of the estrogen plus progesterone containing methods will inhibit the ovulation, except DMPA. DMPA is the only progesterone only method. There is no estrogen here, but even then the studies have shown that there is inhibition of ovulation when we use DMPA. Otherwise, all these things are estrogen plus progesterone, most of them. Okay. Other progesterone only methods like progesterone only pills and LNG IUS, they basically act by making the cervical mucus thick so that the penetration by sperm does not happen. Okay, and then we have endometrial atrophy. These things are common for any method, any hormonal method, the endometrial atrophy, and making the endometrium less receptive for the embryo. There is failed implantation and decreased tubal peristalsis. This is basically due to progesterone component. This is about the mechanism of action. These are the 4 main mechanisms of action for any hormonal method. This is predominant in these methods. Any estrogen plus progesterone containing method and DMPA injections is basically by inhibition of ovulation. And for other progesterone only things like pills and LNG IUS, it is making the cervical mucus thick. So this is a summary of all the different hormonal methods. Okay, all of them are efficacious. You know that all of them are very efficacious, less than 1%. Okay, but there are some of them which are under user control, which are user dependent rather. Some of them are not. Okay, so the failure rate is going to be much lesser in these systems. Okay, so they don't require office visit for pills or rings or patches. They can do it themselves. Injection can be taken by anybody, but implant placement and IUS placement has to be done by trained personnel, right? So they require their visit to hospital. Okay, reversibility is good for everybody. I forgot to tell you, DMPA has a problem with return to fertility. That's one of the side effects. Generally, it almost takes 6 months to 1 year for them to become pregnant once they stop using the injections. That is one of the very important drawback of injectables. That is what I told, Antara, the DMPA injection, depot medroxyprogesterone injection. That's the only one which has very poor return to fertility. Okay, dosing will be daily for pills, implants once in 3 to 5 years, depending on which implant we're using. The intrauterine system, Mirena or LNG IUS, is for 5 years. Rings, I told you, for every 3 weeks, patches weekly, and injectables 3 monthly. Okay. Being discreet, like the girl, probably an unmarried girl or whatever, they don't want, or even a married girl, she doesn't want her partner or her mother-in-law to know that she's using contraception. Discreet is possible in IUS and ring, right? Because they are inside, it's not possible for anybody to see. Pill, they may discover because pills may be lying somewhere. right? And you'll be taking pill every day, and it's not very easy to be discreet. And implants, the impression of the implant can be seen under the skin here, so that is also not possible to be discreet all the time. Patches, depends on what kind of clothes you're wearing, where exactly is the patch placed, it can become evident to people. And injectables, because you have to go and take injections, that's better than other methods, but it is not completely discreet. Now let's see what's available under non-hormonal. Somebody is very particular, they don't want to use hormones because hormones will have side effects. That's a very common notion among general public. So what options we have? If they want a pill, we have a pill available under the government of India, freely available under government of India, called as Chaya. It was initially available as Saheli. Now it is available as Chaya. Okay, it basically contains a non-hormonal chemical synthetic substance called as centchroman, and it's a once-a-week contraceptive, generally known as once-a-week contraceptive. But for the first 3 months, you're supposed to take it twice a week. So you can imagine, remembering and taking every day only is a problem. If you have to take twice a week, you can imagine what will happen. There'll be a lot of confusion. There'll be a lot of missed pills or mistakenly taken after something. So basically the dose is very clearly written on the packet, only twice a week for first 3 months and once a week for 3 months. If you have a mobile and if you can put in a reminder, then probably this is not a bad thing. Okay. Only side effect is it'll cause significant amenorrhea actually. Okay. Because it is potent anti-estrogen and endometrium becomes completely like unfavorable for implantation. That is how it acts. But because of this dosing schedule, like twice a week schedule and then once weekly, the failure rate can be as high as 20%. So it is not under the bracket of highly efficacious like pills and all this stuff. Okay. And the most important non-hormonal method available for us is intrauterine contraceptive device, otherwise called as COPT, commonly called as COPT or IUCD. You should know what are the different types. There are first generation, second generation, third generation, and all this stuff. First generation did not contain any copper. They had only an inert kind of thing called as Lippes loop. Okay, and the second generation contained copper, but it was acting only for 3 years kind of thing. Then we got the third generation, which is COPT 380A, which is commonly available now. Okay, under the government of India, it's available free of cost. It acts up to 10 years. Okay, then we have the hormone containing, that is Mirena, which I already showed you that in the hormonal method. That's a fourth generation. So then we have some newer IUCDs. I'll tell you in the next slide. So what is the mechanism of action of COPT? As I mentioned, COPTs contain copper. Copper is toxic for sperm. So it will lead to destruction of sperms, or it may not completely kill, but it will make them their motility will decrease. They won't act well. They won't be having the capacity to fertilize the ovum and all this stuff. Okay, so that is one important mechanism. Other than that, it will also act as a foreign body in the uterine cavity, right? So it will, the copper and the foreign body itself will lead to influx of lot of macrophages. We can phagocytize the sperm. Okay, it can lead to production of prostaglandins, which will alter the whole milieu in the endometrial cavity, making the endometrium unfavorable for implantation. So these are the different mechanism of actions of COPT. Okay, the advantages are pretty obvious to yourself, right? There is no hormone involved here, and it is not coital dependent. When you can just put it and you can leave it there for 3 to 5 to 10 years, depending on what COPT you're using. Okay. But the contraindications, you have to be extremely careful. See, whenever it comes to family planning methods, contraceptive methods, please remember they are all, the word of mouth spreads very fast. One patient, you overlook the contraindication and insert it, and it leads to complications. She will tell the next, her neighbor, her friend, her relative, whatever, and the whole purpose will get, it will fail. The whole project from the government of India in promoting these things will fail miserably. So we should be extremely careful about the contraindications. The important contraindications are unexplained abnormal vaginal bleeding. Okay, and the chance that the patient is pregnant already. Okay, that is why the placement is done only after menses in cases, and the chance of infection. Please remember that a COPT has a tail. Can you see these threads here? Okay, this part of this thread will be will be cut just below the cervix. It should be visible. It should be felt by the patient. So 2-3 centimeters of this thread will be lying in the vagina. So it will act as a passage for microorganisms to ascend into the upper genital tract, and there is slightly increased incidence of infections, especially if the patient has poor hygiene or if she's susceptible to infections. So we should really look at the contraindications properly. If we think there is any chance of the chance that patient is already having an infection or she's high risk for infection, you should not use. Okay, if she's already got some slightly, increased bleeding during menstruation, menorrhagia, or abnormal uterine bleeding, then you should not put it, because it is surely going to cause augment a particular problem. Okay, then the timing is basically it can be used. Nowadays most important is PPIUCD. All of you know what is PPIUCD. It is post placental placement of IUCD. So once the placenta is delivered and uterus is well contracted, at that moment only we'll put in the copper T, because it's very difficult to convince them to undergo this method at 6 weeks when they come back for postnatal clinic. Okay, but it is very easy to motivate them, because they are going through horrible labor pains and they don't want to go through it in near future again. So it's very easy to motivate them when they are in labor. So whenever a patient who is eligible for a copper T comes in labor, we counsel them during the labor and take the consent, and we insert it off once the placenta is delivered. Because the lady won't really know, right, when we're inserting, she's going through so much of pain and all this stuff. It will be a part of the whole thing for her. PPIUCD has its own problems, the chances of expulsion, the missing threads. Okay, everything is higher in PPIUCD, but it is the best way we can catch women. We can make them adapt this particular method. Okay, our interval copper T insertions used to be, we can count in the fingertips per month, per week. But now, because of our adaptation of PPIUCD, it's in hundreds for us. Okay, so you remember that PPIUCD, the timing itself is very important. Otherwise, if the patient is not willing for post-placental insertion, if she comes to you after 6 weeks of this delivery for postnatal visit, at that time we insert, or anytime post-menstrually we can insert it. It's always better to insert it once the menstruation is over, before the 10 days. Okay, preferably in the first week of the menstrual cycle. How do we insert? The steps of insertion actually depends upon what you're using. Whether you're using I told you about these two are available under Government of India, Copper T 380A and multi-load. This one is essentially placed with a withdrawal method. Here we withdraw the inserter rather than push it up to the fundus, actually. Okay, but this one is not withdrawal method. Just place it up to the fundus and just withdraw the cannula is what we do for multi-load. It's very easy to insert multi-load. Okay, but Copper T 380A, it is by withdrawal method. If it is Mirena, it has got an entirely different system of insertion. So each thing differs. If it is Gynifix, again it involves anchoring the frameless copper IUCD, it's called the frameless IUD, into the fundal myometrium, actually. So it depends upon what you're introducing and what each method. Generally, the package will come with an instruction manual, instruction paper. You have to follow whatever is written in that particular thing. But please remember, for Copper T 380A, it is withdrawal method, and it is not so for multi-load. Just insert up to the fundus and just remove the inserter. That's all we do for multi-load. This is the most easy. If you don't know how to insert, always opt for multi-load. Okay. Then the side effects and complications, as I already mentioned, they can have AUB, they can have expulsion, missing threads, infection, perforation, pregnancy, anything. We have seen a lot of pregnancy with copper T in situ also. Okay, what do we do there is, if the threads are visible, we remove the copper T. Or if threads are not visible, we don't go and search for it. And we don't need to terminate pregnancy also. There is no teratogenicity, there is no harm for the pregnancy as such. But you should tell the patient that she is slightly at an increased risk of infections and complications like preterm labor and preterm PROM and all those things. Otherwise, there is no problem. Okay, we can continue pregnancy. But one important thing you need to know is the AUB. AUB is a very common problem among women who use copper T. You should tell the woman to return back after the first menstrual cycle and give her some NSAIDs or fibrinolytic antifibrinolytic agents like tranexamic acid to cover some cycles. Once her body or uterus gets used to the copper T, the problem will come down by itself. But if problem is not getting relieved, then it is better to remove the copper T if the AUB is significantly making her anemic or something like that. Expulsion can occur. The patient may not realize that she is expelled also. She may just come with missing threads. Okay, we usually advise the patient to feel for the threads once menstruation is complete. Okay, if she's not able to feel, she's supposed to report back to us. That is the instruction which we give commonly to all the women when we insert a copper T. So, and infections, as already mentioned, they're prone for infection, especially if they have a poor hygiene. About perforation, you need to know slightly, like, or rather about missing threads, that's better. Missing threads, if the patient comes with missing threads, generally, initially, we used to tell that we'll do an X-ray, then all those things. Nowadays, we don't do an X-ray, we just do a transvaginal ultrasonogram. If you find that copper T is inside the uterus, only the threads are missing, then we counsel the patient and ask her to follow with an ultrasonogram till whatever time she wants to keep the copper T in. Okay, but if the ultrasonogram shows that the copper T is not inside the uterine cavity, then we will do an X-ray. I didn't mention previously. What's important is, please remember, these frames, the white plastic, whatever we're seeing, that is polypropylene. The lippy slope used to be polyethylene, but both the polyethylene and polypropylene frames are impregnated with barium sulfate to make them radio opaque. So whenever there is a missing thread or a missing copper T, we can take an X-ray and we will know whether it is lying somewhere other than the uterine cavity. Okay, so what's important is, how do you make out where exactly is it? So we place a uterine sound in the uterine cavity, and we take an anteroposterior X-ray and we'll take a lateral X-ray. With that, we'll be able to make out where exactly is the copper T lying. Then we can go in through laparoscopy and remove it. But it is easier said than done, because copper T, as I already told you, is very irritant. So it will attract adhesions. The whole omentum will be forming a kind of ball over there, which we cannot make out by imaging, especially by ultrasonogram. Okay, we'll only know by X-ray where exactly is the copper T. Obviously, X-ray won't help you in making out the adhesions and formation of that omental cake, whatever thing over there. Okay, ball kind of thing over there. So when you put in a laparoscope, you may not be able to find copper T that easily, especially if it is long time lying over there. So you have to remember that, go and follow wherever the omental adhesions are there, you will find it buried in the adhesions over there. Okay, that's about interceptive device, a few things. And I told you lippy sloop was the inert device. Okay, polyethylene with barium sulfate. Then we have all this is the first generation copper T 200, which was useful only for 3 years. Then now we have copper T 380A up to 10 years, and multi-load 250 or 375, either 3 years or 5 years. Then we have Nova T. This has a silver core, actually, copper plus silver core. Even silver lily has an alloy of copper and silver. Gold lily also is available, which is gold and copper. Copper is essential in all of them. Please remember that all these metals can be possible. Iron is never possible in a copper T. Okay, this is an MCQ actually. All the following metals are used in copper T except, okay, copper is obviously an obvious answer. Silver is used, gold is used, but iron is never used. Okay, and I told you about this frameless IUD already. This is called as Gynifix. Okay, this can be kept up to 5 years. Whenever the patient's having problems like menorrhagia and all, this is a better option actually. Now, another important topic under the contraception is emergency contraception. Okay, they say this is what you use when you have not used some protection. Basic indications are unprotected intercourse. Okay, unplanned or unprotected intercourse. Then other than that, we have other indications like rape and incest, where we don't want the young girl or whoever it is to get pregnant. And failure of contraceptive method. I told you the condom burst or missed pills or something like that. There you can go back to emergency contraception. So different methods available are hormonal. Again, estrogen plus progesterone, the famous USP regime, which is not used at all nowadays, or progesterone only. This is available under Government of India free of cost. Okay, and non-hormonal like IUCD, and newer methods like mifepristone. These are the different methods available for emergency contraception for us. Mode of action will be delay of ovulation and preventing the implantation by altering the endometrium. Okay, for the hormonal methods, and for non-hormonal, this is the main mechanism of action. The side effects can be nausea and vomiting because of hormones, because we'll be using a pretty high dose of hormone here. Okay, and irregular bleeding due to any of these methods will be a common side effects of using emergency contraception. Now let's just look at slightly about permanent methods. Okay, permanent methods are surgical methods. For men, we have vasectomy and no scalpel vasectomy. But unfortunately, this method is not commonly followed in our country. There are not many takers. because most of the families, the wife herself will tell, when we try to counsel the woman that you can ask your husband to get it done, they will say, no, he's the only breadwinner. We can't afford him to come and have a surgery and take rest for weeks together. Please tell them that there's a myth associated with the general population over there. We have a method called as no scalpel vasectomy, where not even a suture is placed on the skin, and the person can just take one day leave and very next day he can go back for working, not involving heavy weightlifting and all. But general work can be done over there. So it's especially useful for us whenever the woman is not fit for tubectomy, like case of heart disease, NYHA 3 and 4. Okay, or any other medical condition where we don't want to subject the woman to a surgical procedure. Please remember, even though tubectomy is a minor procedure, it is a laparotomy, right? We have to open the peritoneal cavity, and all the complications of peritoneal entry can be there over there, right? So it's always better that in women, in high-risk women, it's better to advise for vasectomy rather than tubectomy. So coming to tubectomy, it can be done by open method. Mini laparotomy is what is commonly used, or laparoscopically. Okay. The timing of the operation can be puerperium within the first week itself. Please remember, sterilization again is associated with a lot of legal implications, because we can't assure that they won't become pregnant 100%. There is a failure rate associated with any of the methods. So if the patient becomes pregnant following tubectomy, she should not sue the doctor telling that you did the operation and I became pregnant, so give me this much money to take care of the child. So many legal implications will be there, right? So Government of India has taken an insurance policy for the pan India, or people who are eligible to do sterilization are protected under this insurance policy. For every surgeon, up to 4 failures are allowed per year. Okay, so there are a lot of rules and regulations about when to do, when not to do, so that the number of failures come down, right? So puerperium we can't do throughout 6 weeks. We can do only in the first week. Within a week, if we do. Otherwise, you have to do it only after 6 weeks. Okay, that is called as interval sterilization. Concurrent is something which we do along with some procedure. Most commonly, MTP or LSCS. You know that in a multi who's undergoing cesarean section, we'll do LSCS with sterilization. They're all concurrent sterilization. You can't call them as puerperal sterilization. Puerperal sterilization is done after 24 hours before 7 days of delivery. Okay, but concurrent is something which you do along with the procedure. It can be MTP and LSCS, or it can be even myomectomy, Manchester surgery, incisional hernia repair, whatever you're doing. If you're doing a tubectomy along with them, then it is called as concurrent sterilization. And in these conditions, where the patient it's not associated with pregnancy, it will be in interval format. That means you do it immediately following menstrual cycle. Menstruation. Okay, the different methods, what we commonly use is Pomeroy's, because Government of India advises us to do Pomeroy's. We were doing Parklands before. We thought that is better. In Parkland, we make a hole in the mesosalpinx and tie each end separately. Okay, the end result is going to be the same, Pomeroy and Parkland. In Pomeroy, with a absorbable suture, we just make a loop, and the base of the loop we tie, and then we cut the loop. That's all. Okay, it's a very simple procedure, but the end result is same as your Parkland, but slightly higher failure rate when compared to Parkland. But it is not advised to do Parkland by Government of India, because when you're trying to create a hole in the mesosalpinx, it can cause some bleeding and the morbidity may increase. That is why they say that you have to do only Pomeroy's. Okay, then we have the older methods called as Madeliner's, which involves crushing the tube, and there is an increased incidence of ectopic and all this stuff. It is not done anymore. Irving's and Uchitas are basically methods with least failure rates. These are used when the patient is come with failure of sterilization. You have done Pomeroy before and she's come with failure. This time you want to be 100% certain. Okay, not exactly 100%, but better certainty than your usual Pomeroy. So in those conditions, in those situations, we do Irving's or Uchidas. Irving's is basically where we bury the medial end. This medial end, when we cut them, we skeletonize the tube, cut it, and the medial end is buried in the myometrium. It goes back into myometrium. Okay, so that there is no way the ova and sperm can meet. Okay, Uchitas is the one end is left open in the peritoneal cavity, other end is buried in the broad ligament. Okay, so these are the different things. Kroner's is fimbriectomy, just cut the fimbria. This we do when we're doing the vaginal tubectomy. In case of prolapse, you're doing the Manchester surgery and there's an endothelium, you open the peritoneum, you'll get access to the tube. But the most common available part for us is going to be fimbria. We just do a fimbriectomy. Kroner's is the fimbriectomy. This is about different permanent methods. About mini lab and lab sterilization, the differences are pretty obvious. The cost. minimal cost for mini lab, but expensive setup for lab sterilization. Okay, selection of timing, you can do it any time for mini lab, whether it is pure Perl, interval, concurrent, whatever. But lab sterilization is done only in interval or interval concurrent. Okay, contraindications are practically none for mini lab, but for lab sterilization, contraindications for pneumoperitoneum creation. For example, patient is heart disease or some respiratory compromise. Because when we create a pneumoperitoneum, you know that the diaphragm will go up and we can have problems. So it's contraindicating those patients. Complications are minimal in mini lab. In lab laparoscopy, because it's a blind procedure, you can lead to any complication. You can puncture a vessel, you can puncture bowel, bladder, whatever, and sometimes the complication can be fatal also. Okay, hospital stay, mini lab is lesser, 1 to 2 days, but lab sterilization is a daycare procedure. 6 hours in the hospital is enough for lab sterilization. Reversibility again is better with lab sterilization because the amount of tube lost is much more lesser here. Okay. So now last but one slide here. So Government of India initiatives. What are the initiatives by Government of India? Please know that our country is the first country to launch a national program for family planning. In 1952 itself, 1947 became independent. The government realized that population explosion is a big problem in a country, and by 52, the national program was in place. Okay, but there are some problems with this era. You know that you might have heard about forced sterilization of men, forced vasectomy of men, and downfall of Congress because of that. A lot of history you will get when you look into the internet. Okay, but what happened is it got a good boost for the national family planning program when national population policy was adopted in 2000. Okay, and then the national health policy, NRHM, all these things work towards decreasing the family size and providing different contraceptive methods. All these methods which are free of cost all came after national population policy was implemented. Okay, then there is Mission Parivar Vikas, again, where family planning is very important part of this Mission Parivar Vikas. And there's a dedicated website called as Hamdo, where couples can go and see what are the different methods available for them, get all the information they need to know about contraception. And all of you will know that there is extensive media campaigns about contraception, about the different family planning methods available under Government of India. There are a lot of videos, okay, which will be played in between programs in DD1, DD1 into whatever, all those national TV channels. And there are a lot of videos running in bus stations, railway stations, everywhere. The media coverage is very fantastic from Government of India actually, and that is to raise the awareness among the population that these are all available, right? How many of them will go to a website and check out? This very not very doable. So there is extensive media coverage. They'll talk about it in radio also, All India Radio. They'll put posters wherever it can be any of the government setups. They'll have these posters, bus stations or railway stations, PHCs, everywhere there is extensive media coverage regarding this. One last thing. So which are the methods available free of cost? I've been telling it throughout the presentation, but to summarize, we have a barrier method, that is male condom Nirodh, available free of cost. The OC pill, the combined estrogen plus progesterone pill called as Malayan, available. The injectable containing progesterone Antara, DMPA injections, depot progesterone injections. Then we have the non-hormonal pill Chaya. Okay, then we have the easy pill, the emergency contraception pill is called as easy pill. Okay, that's available. Then we have IUCDs like copper IUCD 380A and 375. Okay, which can be used for 10 years and 5 years respectively. And we have sterilization surgeries. These are all available free of cost, whether it is lab sterilization or mini laparotomy. All these are available free of cost under Government of India. Okay, so to summarize, as I have mentioned, contraception is the need of hour for our nation. Okay, please know that there are temporary methods and permanent methods, whatever I've told you till now. And almost all the spacing methods, most of them are available free of cost at public health facilities in our country. At least one among each will be available. So more emphasis by Government of India is being placed on spacing methods like PPIUCD and IUCD nowadays. Okay, and permanent methods are also available at primary health center level onwards. Primary health center, community health center, district health center, it will go on. But it's available even in primary health center or above, and is provided by trained MBBS doctors. But lab sterilizations usually is done by specialists only. Okay, that's it from my side. Any doubts you can ask. The moderator, can you please go through the chat box and see if there are any doubts in the YouTube chat box? There's nothing over here. Can somebody speak? Shweta? Suppose there is one question here. Suppose a female on OCP with contraceptive failure conceives and wish to continue it. Yeah, absolutely. Good question. I forgot to mention it because it's too much to cover in an hour period, as I already mentioned. If the patient conceives on OC pills, there is no need to abort. If she is keen on continuing pregnancy, she can continue. There is no teratogenicity, there is no problem. It will be a normal pregnancy. And if they want to abort, they have all the reason to abort, because you know that it is a failure of contraception. One of the important indications for legal abortion in our country is failure of a contraceptive method. Okay, so both of them are fine. They can continue if they want to continue, or they can abort also. There is no problem. Shweta, can you hear me? Anybody from White Army here?
Can you hear me?
Yeah, I can hear you, Shweta, but your bandwidth is really low. Your voice keeps breaking.
Sorry.
That's okay.
YouTube.
I want somebody to see if there are any questions on YouTube.
In
Otherwise,
YouTube, yeah, ma'am, can you hear?
yeah, I can hear this.
In YouTube, one number has asked what's the difference between Maladi and Maladi and
Mala D and Mala N. Initially, Mala N used to contain norgestrel as a condom of norgestrel, and Mala D used to contain levonorgestrel. Okay, but nowadays even Mala N contains levonorgestrel. There is no difference. There is no Mala D available now. Only Mala N is available. Both of them contain the same contents: levonorgestrel and ethinylestrol. I told you initially, few years back when the pills were introduced, Mala N used to contain norgestrel, 300 micrograms of norgestrel. Hello, the connectivity is really poor today. Can we call it a day? Already we took a long time. I couldn't really finish in 1 hour as expected. I can't hear you, Shweta. Your voice is really breaking. Your bandwidth is really low. Somebody from White Army. Okay, if there are
this is Shweta, ma'am.
Shweta, I can hear you, but only I can hear this is Shweta. After that, your voice starts breaking. Tell me. There's another question here. What could be an ideal contraceptive for married 42-year-old female with 2 children to delay next pregnancy? She wants to become pregnant again. 42 years and 2 children. Okay, if that's an option, Copati is a good option for her. Anyway, she is Paris lady. Okay, because I told you DMPA is not advisable in women more than 40. OC pills can be used. Low dose OC pills can be used. Okay, that's also another option for her. Then we have all the other progesterone only methods which can be used, Mirena, implants, and all those things can be used. But generally, DMPA is not recommended in women who are more than 40. Best thing is, ask them to get sterilized if they don't want to become pregnant. Okay, I think we are ending the session. Thanks everybody for attending the session. Bye-bye. All the best.